Hello, my name is James Neuberger. I'm a liver physician in Birmingham and a trustee of the PBC Foundation. The presentation I'm going to give is an introduction to PBC aimed primarily at those who have been newly diagnosed. It is an overall summary, and other videos and presentations will go into more detail. This is a very generalized presentation, but I hope it's of use and giving you and your family some information about this disease. It's important to stress that this is intended primarily for those who've been newly diagnosed. More information is available on our website, and I do urge you and your family to look at the website. If you have any concerns, you should raise these with your own clinician. We can give information as the foundation, but we can't give advice. I should also stress that some of the medicines I'm going to discuss, which are used by clinicians throughout the world, are not always licensed for the particular indication. So, primary biliary cholangitis, or PBC, was originally called primary biliary cirrhosis, but it was renamed following a campaign by patient groups led very much by the PBC Foundation, because most people with PBC do not have cirrhosis. The disease is an immune-mediated attack on the small bile ducts within the liver. That's to say, the body's own immune system starts damaging the small bile ducts. It is a disease that is progressive, but it progresses very, very slowly and may lead in some to cirrhosis and even liver failure. It's associated with other autoimmune disorders such as thyroid disease and is seen mainly in women, so that for every person with PBC, for every 10 women with PBC, there is one man. Reason for that, we don't know. The diagnosis of PBC is made primarily on two of the three factors. One is compatible liver tests. Two, the presence of specific autoantibodies that are specific for the disease. I'll talk about these a little bit more. And liver pathology that is compatible with PBC. For a diagnosis, you normally need at least two of these factors. The liver tests are also known as liver biochemistry or liver function tests. These are not a good measure of liver function, and we now use the term liver tests or liver blood tests. They include a battery of chemicals in the blood that give an indirect assessment of the state of the liver, and particularly the liver enzymes, ALT, AST, alkaline phosphatase, and gamma GT, and other tests such as total protein, albumin, bilirubin, and so on. So there's a battery of tests that give you a picture of the liver, but they are not diagnostic and they are not specific for PBC. The liver tests in PBC are usually associated with a rise in alkaline phosphatase and gamma-glutamyl transpeptidase or transferase, often known as GGT. Other tests may also be abnormal, but the ALK-Phos is the most useful guide, as it will discuss later, suggests how you can monitor disease and see if there's a response to treatment. Antibodies are chemicals, proteins largely, that are produced by the immune system. Autoantibodies are those antibodies which recognize components of self. And the antimitochondrial antibody is virtually diagnostic of PBC. Mitochondria are very small organelles within almost every cell in the body, except indeed red blood cells, and these are the powerhouses that produce the energy. why PBC is associated with antimitochondrial antibody is not entirely clear. There are other autoantibodies that are specific for PBC, and these are anti-nuclear antibodies that recognize proteins on the nucleus of cells, and these are termed SP100 and GP210. There are other anti-nuclear antibodies that are found in other liver diseases. Now, a small proportion, maybe 1 in 10, 1 in 20 of people with PBC do not have antimitochondrial antibodies detectable. And it's worth noting that in treatment, AMA may go from positive to negative. Also, after liver transplantation, AMA persists, whether or not there's recurrent disease. Other investigations that people will do in investigation of PBC includes an ultrasound, a fibroscan, maybe CT and MRI scan, and endoscopy. The fibroscan is being used increasingly as a simple way of determining not only fibrosis, but also fat in the liver. It's a non-invasive test, it's easily done, and gives you a number, and the higher the number for the fibrosis, the greater the chances there are of having cirrhosis. The liver biopsy used to be used frequently to diagnose PBC, but as we have got better at testing for it and greater awareness, liver biopsy is used less often. This is a picture of a liver biopsy from somebody with PBC, and as you can see, there are a lot of inflammation around the small bile ducts. The main reasons for doing liver biopsy in those with PBC is if there's doubt about the diagnosis, there's possible overlap syndrome, or other potential causes for PBC, for the abnormal liver tests. Now, the main symptoms that are specific to PBC are twofold. There is itching, which is known medically as pruritus, or lethargy or brain fog. Now, itching is fairly clear-cut, and there are many causes of itching, and itching can be very severe. The lethargy or brain fog is a much more complex issue. It's less clearly defined, although we all know what it is. And there'll be more specific talks about this in the series, and I do urge you to listen to them. It's important to stress that neither the presence or the severity of these symptoms relate to the severity of liver disease. So you can have very severe PBC and no itching or brain fog, and conversely, you can have very severe itching with early disease. We are quite good now at treating the symptoms of itching. The mainstay of treatment of itching is cholestyramine or Questran, a drug that was initially used for the treatment of high cholesterol. But there are other medications, rifampicin, naltrexone, and so on, which do help in the treatment of itching. But many of these, I have to say, are not licensed for the use in treatment of itching in PBC, but nonetheless, they are effective and are well used. All drugs have side effects, and one has to balance the risks and the benefits. Your own doctor or nurse will talk to you more about that. Liver transplantation is very effective for the treatment of intractable itching, and I've seen people who have been tearing the skin apart wake up the day after transplant and the itching has gone. Lethargy, on the other hand, or brain fog, which can be very debilitating for many people, we don't understand the mechanism, we don't have any effective treatment. It's important to consider other factors that may cause lethargy, such as thyroid disease or medications. We do know exercise helps, and self-help can be of great value, and again, more of this in other talks. It's important to stress that unlike itching, transplantation does not help the lethargy. So we would not offer transplantation for people with lethargy, however severe it may be, because the transplant does not make a big difference. The lethargy is real, it is serious in many people, and it is not something you can snap out of anything more than you can snap out of appendicitis. As far as specific treatment for PBC is concerned, at the moment we don't have a cure. We have an increasing number of treatments that control PBC and slow it down. The initial drug that was shown to be effective was a drug called ursodeoxycholic acid, referred to also as urso or UDCA. This was found in bile, and it's particularly seen in bear bile, hence the name urso. I should stress that it's the brown bear, not the polar bear, and nowadays the urso is not made from bear bile, so no bears are harmed in the manufacture of urso. More recently, obeticholic acid has been shown to be effective, and we use that increasingly for people who are either non-responders to urso or cannot tolerate it. Other drugs that are being used particularly includes fibrates, bezafibrate, which is being evaluated in this and many other countries. Now, we know that urso, here it's shown the chemical structure, is the first-line treatment for urso. It's a naturally occurring drug. It's associated with improvement in the liver tests, in survival, and in the degree of scarring in the liver. And this is just one graph showing how responders to urso do so much better in terms of survival than non-responders. It's important that the dose is appropriate, and the dose should be between 13 and 15 milligrams per kilogram per body weight per day, and this should be lifelong. We do see a number of patients who've been advised to stop the urso once the liver tests have returned to normal. This should not be followed. You should stay on this lifelong. There are a few side effects with urso, particularly bloating or diarrhea, but none of them is serious, and none of them cannot be controlled in the majority of people. Now, we talk about the response to urso, and we measure this biochemically after 6 or 12 months of treatment. Several groups have defined responses, which are shown there, but basically we're looking for a lowering towards normal of the alkaline phosphatase, and levels below 200 or 240 are usually considered a response, but the precise definitions is shown in the table. People who don't respond to urso biochemically are termed incomplete responders, and then we would consider second-line treatments such as fibrates or obeticholic acid. PBC is associated with a number of other conditions. That's presumably because there's a genetic component to this, and particularly thyroid disease, where the thyroid is underactive, it is easily treated. Many people have Sicca syndrome, which is where you get dryness of the eye, of the tear ducts, the salivary glands, and in the vagina, leading to dryness, and that needs its own treatment. Raynaud's phenomenon or Raynaud's disease, where the hands get affected in the cold, celiac disease, arthritis, bone disease, and other autoimmune diseases. The reason for mentioning this is important that if you have PBC, your doctors or nurse should consider other autoimmune conditions and offer treatment if and when indicated. Some people with PBC do go on to develop cirrhosis, and cirrhosis from any cause does need additional monitoring. The two major effects that one needs to be aware of is firstly the development of varices. These are varicose veins in the gullet in particular, but can occur anywhere in the GI tract. These can bleed, and if we know that somebody has varices, we can offer them treatment to reduce the risk of bleeding and, more importantly, the mortality associated with bleeding. So anybody with cirrhosis from any cause does need to have tests to see if varices are present. The other side of complication from cirrhosis is the development of liver cancer. Now, this is seen particularly in men and rarely in women, but it can occur, and early diagnosis can often lead to cure. So again, people with cirrhosis should be monitored for the presence of liver cancer. So I'm trying to get the next slide up. Apologies. Liver transplantation has become, certainly for the clinicians, almost a routine procedure. Obviously, for the patient, it's a major treatment. And basically, it's now become very successful. We consider liver transplantation for those with end-stage liver disease. The liver is likely to fail within 6 to 12 months, or intractable symptoms such as confusion or severe itching that can't be controlled by other means. The outcomes for PBC are usually amongst the best. There's rapid improvement in itching, and as I've said, little improvement on the lethargy. PBC often recurs in the graft, and we'll talk more about that in other talks, but it's usually of little impact. And it now seems that the use of urso post-transplant also improves the outcome. So in summary then, PBC is a chronic liver disease. The cause is not known. It is not related to alcohol. It is not related to any known behavior. There's some interesting pointers, and if you watch the video on epidemiology, you'll find some interesting pointers, but we still basically don't understand why some people get PBC. The symptoms of PBC primarily are itching and lethargy, or tiredness or brain fog. Urso is the first-line treatment with a recommended dose of 13 to 50 milligrams per kilogram body weight per day, which should be lifelong. For those who don't respond to urso, there are other treatments, and liver transplantation is effective in prolonging life and improving the itching. It's important to remember that you should take ownership of the condition. We are keen to support people knowing more about the condition and being able to discuss it with the clinicians, the doctors, nurses, pharmacists, and so on. But PBC is uncommon, and you will find that in many cases you will know more than your doctor, and you shouldn't be afraid to point that out, although I suggest tactfully. And finally, you're not alone, and the PBC Foundation is one of several organizations that are there to help you, provide support for you, put you in touch with other people with the condition. Membership is free, and we do encourage you to join and contribute. Thank you very much for your attention.